a department, or they typically have, if not a department, they have a person who is in charge of all those documents. So when you, in your department, fill out an incident report, it must go to person A, who then takes it to maybe a team meeting where they assess what happened, and invariably there is feedback. So most organizations have actually a system for incident reporting. So these might be things that we might need to implement in order to avoid incidents in our own work environments. Another form of quality improvement strategy is electronic health records and data analytics. With everybody who uses an EMR or EHR would know that most of these systems have an analytical piece to them. So an EHR improves access to patient information and enables tracking of performance metrics in real time. So I know we don't have that yet in Nigeria, but I know in England and here in the US, I know that basically now they have, most places you go have a medical record system where once one facility puts in your information, somebody else can see it. So like when you have a baby, they start almost like a health credit record, a health record system, where once you have the kids have their vaccinations, when they go to their pediatrician, they log into that same system. So they can see all the vaccines. They're not relying on the patient to write it on a piece of paper. They will have it because of the electronic health record system that's in place. We're not there yet. It's not centralized. A lot of places now have electronic health records, which helps in a hospital setting. You don't want to be telling your history to every department you have to go to. The idea is once a hospital system has electronic health records, everybody who needs access to it can gain access to your records. Again, there's a privacy piece to it as well. But also the electronic health records gives you advanced analytics and dashboards that help identify trends, monitor patient outcomes, and pinpoint areas for improvement. Some of the ones I've seen, it will tell you, I mean, I'm a physiotherapist, so if you're looking at a physiotherapist EMR or EHR, it will tell you, okay, physiotherapy A saw X number of patients in the week. And it will tell you the diagnosis, what category of patients did they see, etc. So it can give you a lot of information. And because EHR is time sensitive, it knows when you log on, when you log off. It can also monitor timing as well. And then you have patient-centered care, which focuses on involving the patient in their decision about their care, ensuring that the care aligns with their values and needs, not what you think the patient needs. Also, and examples include shared decision-making, use of patient feedback surveys, and improving communication between providers and patients. So patients can give you information to say, okay, yes, this is, I did this in this place before, I don't want to do it again. Or this is what worked for me the last time. I don't know if this can be implemented here, or just sharing of information. And you want to have that line of communication open. And we have to start it. Us providers have to be the ones to start it. If your patient comes in and they feel like you are not approachable or they can't talk to you, then it's gonna be hard for you to have patient-centered care if you can't communicate with your patient. Performance-based incentives. This is rewarding healthcare providers for meeting specific quality benchmarks, such as reducing readmissions or improving patient satisfaction scores. This can drive performance improvements by linking financial incentives to quality outcomes. So I know a lot of some clinics who they have all this data in place to see, okay, how many patients did you see? How many came back? How many didn't come back? How many met their goals? And based on numbers, some of them is just based on numbers, how well that department is doing. If some actually set goals, and you can only do this when you start implementing these systems and you have initial data to work with. You can't have an incentive if you don't know how well you're doing. So you first have to assess how the department is doing. Okay, so when they started, we were only seeing 10 patients in 8 hours. So you know that's what you were doing. So your goal is, how can we improve that to double the number of patients we're seeing in that same period of time? So once you have your baseline, you can now set outcomes and say, okay, each time we hit 30 instead of 10, everybody gets a bonus. So you are now, the driving force becomes, the incentive. So it's based on performance. So you do well, there's an incentive. You have team-based care, which is emphasizing the importance of multidisciplinary teams working together to deliver comprehensive care, and also collaborative practice models enhance communication, reduce errors, and improve patients' outcomes. Again, the importance of teamwork sometimes can save a lot of issues down the line, because the right hand knows what the left hand is doing. So that makes it a big difference. Continuous education and training is also part of quality improvement, which is what we're doing here today. Regular training on best practices, emerging evidence, new technologies, all of this helps to maintain a high level of competence among healthcare staff. We cannot continue to be relevant if we don't continually train ourselves. Because things are changing and getting better. And if there's a better and easier way of doing something, that's where we should go, not what we're used to doing. Well, it worked. I used to do it 10 years ago. Well, this is 10 years later. We need to do something a little bit better. So regular training is key. Simulation-based training is often used to practice responses to critical incidents, like drills. So this is talking about, is more in bigger institutions, but you have what they call fire drills. So in a hospital or in an organization, they will practice fire drills. You have your fire exits. Each department, especially in bigger facilities, so you don't have bottlenecks. There are exits where department A, B, and C have to go this way. Department D, E, F go this way. Another department goes this way. I mean, a lot of places do fire drills. And the idea is you practice something so that if in the event that critical event happens, everybody knows what they're supposed to do. you know, when in hospitals they'll have code red, different codes for different incidences. People are trained. Okay, so if on this floor, if there is a code red, the doctor in this department needs to come, the therapist from this department needs to come, the nurse from, so there's a system, it's written down, it's documented. This is the plan. So when this happens, this is what we need to do. So not only are those plans implemented, but they're practiced. That's the simulation. So you practice where you're supposed to go if an event happens. Some people is if there's a threat of a hurricane, if there's a threat of inclement weather. A hospital I used to work on, they used to tell us when we did our drills, okay, if there's sometimes, you know, you have terrible accidents on the motorway where maybe 10, 15 cars are involved. If they start bringing people to the ER, when the ER becomes full, okay, physiotherapy department, you are on the same floor as the ER, you will be like the triage. So patients who are not bleeding will come to physiotherapy. So you practice all those things. So when those events happen, there's a system, there's a plan. And you've done drills where you do a dry run, as they would say here. So you practice doing these things before the event happens. So when the event happens, everybody knows what they're supposed to do. That's why we do CPR training. Why do we do CPR training? That's a drill. We get CPR certification, not because we're practicing on somebody who is not breathing, but we practice what to do. So if we are presented with somebody who's not breathing, we know how to do CPR. So CPR is basically a drill that you train for in the event that you're you're present where somebody stops breathing or their heart stops. And that's all under continuing education. In America, I know I think the Heart Association, American Heart Association, now allows when you do your CPR training, it lasts for 2 years. Before, it used to be 1 year. So when you get your CPR certificate, it's good for 2 years. Why? Because we forget. New things change. Before it was you do 2 compressions and 15 breaths. At one point, it used to be, I think it was a different number. I can't remember. I don't want to give wrong information. I mean, over the years of my career, I've done it obviously many times. It used to be every year then, now it's every 2 years. But my point is, research has shown that things change. Before, when if it was a drowning accident and they're choking or they're not breathing, sorry, because if they're drowning, they're unconscious, but they're not breathing, they always used to say, put something if they collapse and you think they collapse, because sometimes if people choke on something, they can't breathe, then they collapse. So if you are not sure that what they ingested, before they used to tell you to put your finger in their mouth and sweep to the back of their throat. Okay, ladies and gentlemen, you don't do that anymore. You put the patient on the side and continue doing what you've done. So they discovered putting your hand in somebody's mouth doesn't work anymore. Same thing with somebody who's having a seizure. Before, they used to tell you to kind of restrain them, roll them on their side, restrain them. Now they tell you, clear the area and leave them alone. So if we're not continually training ourselves, we're not going to know what's new. So that's why for CPR training, you have to go and redo your training every 2 years. So you know what is changing. Because things are changing, thank God, due to research. And that's the fundamental baseline of what we're doing. And when we do all these things, our practice, our outcomes, patient-centered, and we have good outcomes. Public reporting. Okay, this is the last one. Making healthcare outcomes and quality data publicly available to increase transparency and accountability. When people know what's going on, or when people can see what's going on, we do better. I think that's just a human nature thing. You know, people always sometimes will say, behave as if somebody's watching you, even when nobody's there. Then you do the right thing. So it's the same thing here, is when you make your information public, people are more accountable. We're all in so many groups, so many organizations where you have to pay money for things. The minute they post a list of the people who have paid, everybody else starts paying. So that's what it's saying, that when you make your data public and available, it forces you to be accountable. Every restaurant in America is assessed. They have health inspectors that come and assess them, and they give them a score. Every restaurant must post that report on their window. So when you go to a restaurant, you can see, did they get 100%, 80%, 50% to know whether you want to go there, eat or not. So because they've made that public knowledge, it forces that restaurant to do better the next time, because they know their report is going to be pasted on their window. So that's what it means about accountability. When you are transparent and you publicize your data, you know that the next time you do a review and you're going to make that report public, you want it to be better than the last time. Or if you're saying, I'm the best in the industry, you want to make sure you stay being the best in your industry. It encourages competition based on quality, and it pushes providers to continuously improve. So it forces us, it really does forces us to ensure that we're doing the right thing. So that's the end of this section, going through what some of those strategies are. Before we go on to the next section, I think we can have like a 10-minute break, and then we can come back and continue. I don't know, my co-host, is that okay?
That's fine, ma.
Okay, so we can, my time says something 42. Let me see, mine is
11:42.
42. Okay, so we can come back by
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 12.
by 12. Okay, so we resume by 12.
Yes, ma.
Okay,
Thank you very much.
you're welcome. Just gonna mute myself.
Thank you for your time. It's break over. It's 12 o'clock already. So, Ma, you can
Yeah,
start
yeah.
now. Thank you, Ma.
Okay. Okay, so based on all what we've discussed this morning, I want to, I mean, can people come up with, in each area that we all work, or in any situation really, can anybody share or bring up an issue that we can look at to see which one of these would be relevant in terms of trying to improve um, provision of services? Or are there any of these examples that have been worked on in your facility that you can share? I would like for this not to be a monologue. And when we have a large group like this, sometimes we can dim a lot from other people's experiences or just issues you think, how can maybe we can brainstorm in terms of, how can we help? Anyone with any ideas or any thoughts? Is everybody there? People can raise their hands. I may not be able to see the hands, but I know my co-host probably could. Does anybody have any scenarios? Because sometimes the way to practicalize this is to at least discuss different cases. Hello? Everybody's very silent.
Could you please repeat the question, please?
Okay, my question was, are there any situations in anyone's facilities or the environment where you work that you think any of these strategies can be applied? Either is it an ongoing problem that we can discuss and see what we can do, or a situation that has risen and you've been able to resolve it through one of these, just to share your experiences. Or maybe an area in your facility you think could be improved, and maybe we can just brainstorm on how possible scenarios.
So the area that comes to my mind right now, it's in the realm of research.
Okay.
At least while trying to make up the research population, we could actually make use of it in deciding the type of sampling techniques to use or those to gather as the participants that will work in the research.
Okay, can I ask what are you researching? Do you have your research question?
No, like I'm not talking of a particular one right now. Like
Just in general.
yes, general. Like when you're preparing to probably go into the field, and then maybe in drawing up a questionnaire to decide whether it will follow the experimental or the survey. It could still work in thinking of those to use, either those to interview, those to put in the experimental group, or those to give the questionnaires to fill.
Okay. So what I would say also with that, does anybody else have a suggestion? So if you have your, just speak up. I can't see hands. So, I mean, like, oh, was it Mr. Coyote that just spoke?
Yes, it was.
Okay. Yeah, just speak up. So what it can help with is like fine tuning what you, when you have your research question, then it's easier to know which one of these would best fit when you, but you know, then you're doing statistical analysis of your data. That's on one side, which is, you know, different. Some of these were kind of like problem solving. So what the way this could help is the next piece we're going to do is collecting data and feedback. How do you do that? So I think that might even be more relevant to the point you just raised, is how do you go about getting information? But I think the important thing is to know some of these are streamlining a process. The other part is collecting the data you need to streamline that process, to be able to problem solve and do one of the methodologies to assess and implement a plan. So once you have a research question, I guess my first question would be, when we do research, and I heard somebody say that recently, because somebody was asking, what topic can I do research on a platform? And somebody responded that, well, you have to look at your population, look at where there is a need to improve a service, and then come up with your research question. Because if not, you are not going to have, like you were just saying, who do you give your questionnaire to? If you want to research a topic that you are not directly involved in, you're not going to have subjects. Does that make sense? So have a research question based around your facility, issues around your facility or things you see often. I mean, I will give you an example. Well, this is a good example, maybe. I am not into research. I should do better. But one area I know that I think if I'm pushed into doing it right now would be finding out the incidence of female patients or the causes of vaginismus in female patients within a certain age range. Now, why would I choose that topic? I'm seeing a lot of patients who have it, and I'm like, why? So many young people who are married and cannot consummate their marriage because of this condition. So I could do a research based on that because I have the population. At least I'm seeing those patients and I can follow through with treatment. I can follow through, you know, so pick an area that you have the subject to choose from, because the validity of any research is numbers. If you do a research with 5 patients compared to somebody doing the same research with 100 or 1,000 patients, then you're obviously going to have more, your research is going to carry more weight the more subjects you have. So aside from looking at how to get your information, look at what information, what are you trying to improve or get answers to? Research is finding an answer to a question. That's what research is. And finding out, okay, what's the best way to go about this, or what's the best treatment for this? We have a question, so we research to find an answer, or we have a hypothesis. So, so the next part is, does anybody else have anything else?
There is a question here, Ma. Someone says, what is the best way to transfer patients from one multidisciplinary team to another in a situation where you don't have any student on posting who can easily do this?
Okay. I don't understand when you say from one multidisciplinary team to another. And what's the correlation with the student?
Okay.
Can the person
Homona
clarify?
Chigozie, please kindly unmute and clarify yourself on this question. Thank you.
Good morning, everybody. Have a good afternoon. Thank you so much for the lecture so far. My question is that in a situation where you don't have this electronic health record that you can easily transfer electronic patient history, from one department to another, in a situation where we are still using medical cards, what is the best way to avoid conflict with other members of the team managing the patients to do that and also to save patients time? I don't know if it's clear enough.
Yes, it's clear. So, okay, so you're still using paper and pen, basically. And so my question to you would be, do you do an evaluation? Let me rephrase that. Of course you do an evaluation, I'm going to assume. But is it on paper? Is that evaluation on paper? Do you have it written down?
Yes, everything is on paper.
Okay. So what I would do if in that scenario, and I want to make sure, the other question is, what is your relationship with the other team members?
The relationship is, I would say, is satisfactory. It's very good. But in situations where you have a lot of people to attend to, there can be a lot of hostility, maybe in delay. Okay, for example, now you tell the patient, okay, please go. It's not right to give the patient the file to handle themselves. So please
Okay.
go to this team and wait. I'll as soon as I'm free, I'll find an opportunity to send this file to that team you are visiting. But in a situation where there is a slight delay and all of that, the scenario
Okay.
can change and the environment
Can I
can be a
ask,
little hostile.
can I ask for clarification? When you say to go to that department and wait, so you are I'm not going to assume everybody's a physiotherapist on here. So what's your
Yes.
discipline?
Prosthetics, orthotics.
Okay, so where are you sending them to?
Okay, sometimes we send them to, for example, the physio unit.
Okay.
For muscle exercise and all that. For
So
them to do their own evaluation as well.
Okay. What I would recommend so the idea is you leave here with a solution, at least that's my own thought. Okay, and this is all part of, professionalism is, we're all in our own spheres, but we also need to know how to communicate effectively with our team members. And this is a very good point you've brought up, because not everybody still has electronic medical record system. I would suggest you guys would have, like, we're still doing paper and pen. You are not going to send the patient, if you can't send them with their record, I would recommend your department comes up with a basic referral format, a piece of paper that's a referral sheet. We can print those are inexpensive, or just have a notepad and let the physiotherapist know. So communicate with them ahead of time that, look, when we see patients, and when you, in your lunchtime or your free time, you have a conversation with them, if you don't have interdisciplinary team meetings, that, look, just to save on time, when we have patients we're sending to you, we're going to just send them with a note for you to assess and the kind of device we're giving them. So you've already set the stage for communication to occur. So when that patient comes to you, you do all you need to do for the patient. You get your notepad and you write patient's name, date of birth, referral from orthotic department, patient is receiving an AFO, please evaluate and treat, or whatever you want them to do. sign it, fold that, give that to the patient. It's like you're giving the patient a prescription. The patient can take the prescription and they can then take it straight to the physiotherapy department and boom, you don't need to go there. Does that answer that question? Or does that help? Is that something that's feasible? I mean, I don't know the culture in your hospital or clinic. So is that something that would fly?
I've tried that on several occasions. To some, they understand, while
Okay.
to others, they feel it's a little disrespectful sending a case note without the case file. But sometimes we are constrained with the amount of people we see and the amount of people that are, helping us to
Can I ask
transport.
her, the patient with the fare? So your policy in that facility is that the patient cannot take their case file?
No, the patient cannot take their case file. That's the policy here.
Okay. Okay, can we brainstorm this? We have 97 people on this platform. Can we have some ideas? How, without changing, obviously changing a policy in a hospital or clinic will take time. And these are issues. Do you have interdisciplinary, or do you have managerial meetings where all department heads go? Hello? He says he cannot unmute. To the host, he says he can't unmute to answer. I mean, this is a perfect example for us to use. So you have meetings, okay? Can this be brought up at your meetings whilst the host is trying to get you to unmute? I mean, I pulled up the chat so I can read. So when you bring it up at the meetings, what he's saying, so let me read what his chat is saying. So they do have meetings. It says, yes, it has been an issue for a while now. So when you bring it up at the meetings, what are they saying?
So the management is suggesting that the nurses takes charge of taking the case files from one unit to another. And the nurses are refusing because they said it's not part of their job description.
Oh
so
my God.
I do not know what to do.
Okay. Okay, somebody had said hi. I don't know, Dr. Grace, I don't know if you had something to add. Let's see if we can find a solution that he can go back with. I mean, that's the purpose of continuing ed. We learn stuff and let's practicalize it. Meetings depend on where the professionals practice, private versus GH or teaching hospital. So where are you?
It's a privately owned facility, not a general hospital.
That should be easier to make change now if it's private, because I mean, and so are you part of the meetings, or is it somebody senior to you that goes to the meetings, or are you the one?
If I'm available on the meeting day, I participate. But if I'm not available, somebody superior to me. The management, the facility has assigned the nurses, but the nurses are refusing to do it. So after each meeting, they tend to do it for a while and then they stop.
Okay. Is your facility looking at electronic?
Yes, they are. They are seriously working on it because of probably these issues. They are working on it. They've contracted the company that is working on it, but we have issues with power. Those things can affect. And since it's a
That's a Nigerian problem there. Yeah.
since it's a privately owned facility, management is looking at the cost of running diesel
all day.
all day. So, well, they are still considering a lot of things. I don't think it's an immediate.
Okay, so we want to get your. So you made a comment in the beginning that I was a bit puzzled about. That you said when you send those notes, some people, like some of them accept it, some think it's rude. Is that in the physiotherapy department?
It's understandable for physiotherapists because we are all in the MRTB. We are like a caucus, like a cartel.
Okay.
But trying to go to other units, maybe probably the doctors for review, maybe when the patient is complaining of the scar on the residual limb, all those things. They feel like,
okay, so when so how would they want you to respond?
they want us to always bring the cards. They want
But
us to always bring the cards.
don't they understand that there's an issue with that process?
They do, because they attend these meetings too. So for them, it's easier. The nurses will always oblige, will always take the cards on their behalf. They ring a bell and the nurses will appear, take the cards, but the nurses are refusing to do it for other
departments.
And I don't understand why. If they can do it for
one department, they should do it for all.
They should do it for all.
Because if they didn't, I hope we're going to get slides. Oh, okay.
Hello, ma.
Yes.
Good morning.
Good morning. Go ahead.
Please, my name is Dr. Absalam Yakase. I want to contribute.
Please.
In this regard, in most instances, it happens. The should not be the one, transferring the files from one department to the other. I think there should be a hospital assistance. That is what is happening in most of the places, because the patient should not handle the file, and then there should be a hospital assistance that will be maybe transferring the file from one place to the other. Though there should be a kind of a file for each, maybe probably general file and a kind of departmental file. So maybe the reason why they wanted to get a file from that prosthetic and orthotics department to see what happened, and then there is no need for nurses to be taking the files from one point to the other. I don't know why it's happening in their own facility, but it should be a kind of hospital attendants. That is their work. A lot of them, then they can take a file, even with the patient, to the respective a kind of department or unit. Thank you so much.
Okay, thank you. I was going to say that because typically hospitals, you have porters or, like you said, assistants who would even like transport somebody who's in a wheelchair from point A to point B. Don't you have that? Because if you have that, I mean, really, honestly, truly, it is not enough. If I was a nurse, I wouldn't want to do that. I'm not a messenger, to be fair. I didn't go to school to be transporting files. But like you say, obviously, they can't say no to the doctors. We do have the supposed hierarchy. I say that. But still, I mean, we're all professionals in our own right. And so are the nurses. So, but do you have like porters or assistants in that facility? Oh, they don't. Oof. Okay. But one thing I would do is maybe have a conversation. Yeah, the digital records would definitely take away this problem altogether. Like you said, Dr. Grace is talking about computers, power, and maintenance. yeah, those will definitely be other issues that they would need to work on, considering a system in Nigeria for the, let me just say, a lack of infrastructure. But what I would recommend, and I tell me if this is feasible or not, is it seems like you have to, your department, because this is an ongoing problem, and really you're really trying to help the patient, because you are not saying, okay, go sit and wait for me, which is what happens in the average Nigerian environment. They have no respect of people's times. Sorry, that's my perception since I've been there. In a lot of places, some places are getting better, but people don't respect other people's times. So what I would suggest, can you have a one-on-one? This is not in your meetings. Is there somebody central in the doctors, with the doctors, that you feel comfortable or that you have a rapport with? And this is why it's important for all of us to have communication with everybody that we work with, and no antagonism. Because when we have people that we can talk to, or that, no, let me not say that, when we have relationships, and it can just be working relationships, when we have these relationships, it helps solve some of these problems that are really institutionalized, but the institutes cannot help us. But if we have a professional relationship with all the other departments, you have people in there, you go say, hi, I'm this, just coming to say hello. I know a lot of that doesn't happen here, because we have, this one is, everybody wants to be autonomous. We're not, we cannot. Doctors alone cannot run a hospital. Physiotherapists alone cannot run a hospital. Nurses alone cannot run a hospital. Orthotists alone can't, you know what I mean? So it's like the body. You need your legs, you need your arms, you need your head, you need your body, you need everything. Is that a feasible option? Or maybe I'm just being idealistic. Is there somebody amongst the doctors that you can talk to who can help you to say that, look, this is the situation. Yes, management has says nurses should bring this. I'm not reporting nurses, because really, if I was a nurse, I wouldn't do it too. But the nurses will take the cards from you, but they're not doing it for every department. And we're trying to save time, go from a patient angle. That, look, the patients are coming, they're waiting for hours. Can we please just continue to send notes? And then as soon as we can send the file, we will send it. Is there anybody that you can have that conversation with? Mr. Are you muted again? Is it Miss Umuna? Did I say that correctly? Let me.
Okay, yes. I'm responding in the chat box.
Oh, I just saw that now. Yeah, I was flipping up to get your name. Sorry. So there is somebody you think you can have that conversation with. Oh, you've gone again. Come back. Okay, Dr. Grace says that's tricky. Please, what do you mean by that's tricky? Because now we're not reporting anyone. He wants the system to work. He doesn't want the patients to be waiting for hours. That's his only investment in this. No, that's why you said the consultants are usually high-handed. He says there is somebody he can talk to. I can also speak with the nursing officer. So yes, that's why if you, Dr. Grace said those consultants are usually high-handed. That is why my comment was, is there somebody he can talk to? That was my question. I didn't say go there and talk to them. And he is saying he has a relationship with somebody that he can talk to. And that's the key. When you have relationships, you can have these conversations. And I don't think I'm being idealistic. That's just human. We can approach people that we have relationships with. And I don't mean, it's not a relationship outside of the clinic, but people you see, hello, how are you? You talk to, I mean, you develop some kind of a relationship when we're at work with people. So you're saying they're difficult to reach. Okay, so in this instance, I don't think that's an issue because he's answered my question. Because I asked, is there somebody you can talk to? If he said no, then it's a moot point. There's no point me even moving forward with my remark. So he does have two people that he can talk to, both in the nursing arena and in the doctor's arena. So if he has those relationships, he's not going to go and he's not reporting. Please get me, understand what I'm saying. We have a system. We want it to work. You said the same consultants don't get to see the patients on every visit. I understand. Okay, but what, Dr. Grace, stop putting roadblocks. This is why we don't move forward, because we put roadblocks. You know how I act? Let's try something, let it fail. If it fails, we go to plan B. If plan B fails, we go to plan C. But if you don't start, you won't know. He might have a conversation with the first doctor, and then this is a moot point, and his problem is resolved. Let's go for resolution. Let's not look for the roadblocks. And sometimes the person that you think will be the most difficult will be the one that will give you your solution. So, Mr. Umuna, please, and I would really love to get, so help us God. Dr. Grace, okay. I would love to get feedback on this. Where are you located, please? Because this is the point. We learn something and let's try to use it. No matter how, it's no point us learning and it's in our back pocket or the PowerPoint is in our computer. Oh, you're in Lagos, perfect. Okay, so we can talk offline. I don't want to get you to divulge information, but I would love to hear what happens. Because, I mean, the next time we talk about these things, this can be an example that, look, there were many issues. We gave suggestions. The person went back, you implemented. That's the thing with all these things that it's not just theory. Well, what we're looking at in the PowerPoint is just theory. But can we practicalize it for our day-to-day practice to get better? And that's what I want to see in this situation. I mean, he's not going into in-depth methodology, but this is part of the, it wasn't continuous assessment. Let me see if I can go back. This is what we're looking at in terms of team-based care. That's what we're looking at. You have a team. Can we collaborate? That's what we're asking for, is collaboration. That, okay, this is my problem. Please, it's not that we don't want to come. Just like you have a lot of patients in your clinic, so do we. And we don't have the manpower to send somebody with each patient. And we would like for the patients, some of them are coming from far, so they don't have to wait. So please, can we still just at least send the notes? And maybe the minute we have free time, we'll bring all the notes to your clinic, and talk to the nurse. Say, look, and there's nothing like when you're empathizing with somebody that you feel their pain, they will understand you. Not that you're high-handed. In the management, they say you should do this, you must do this. You're not going to get results. Look, I'm an orthotist. If the doctors had said for me to start running around delivering charts, I would not be happy. So I understand, but always put the but. But if there's any way you can help us, we would appreciate it. It may not be all the time. So you see what I mean about the relationship, and when like I said to people, what we say, Okay, absolutely. A multidisciplinary team intervention is great, but the background of the different professions and approaches of management cause clashes, ma. I understand that. We have to change this rhetoric. We must change it. Because if we do not change it, we're not going to move forward. And Rehab 2030 is about rehabilitation and teamwork. If we all don't work together, the patient suffers. And guess what? Our work is made harder. So I always say to people, because I didn't school in Nigeria and I didn't work in Nigeria, this is my own story, for want of a better word. I have come into Nigeria with a completely, I call it a blank slate. I have no limiting beliefs. I have no inhibitions. I have no hangups. I have no, there's a word I'm looking for that is not coming. So when I go in with an open mind. And I think a lot more of us need to do that for things to change in Nigeria. Okay, Ma, for this approach to work, they need to first of all, in the prosthetic and orthotic unit, designate the duty of delivering the files to someone. This way, someone is responsible for doing that and at a time schedule, measures for better working. So that, in fact, that's what I was going to say is, you know, you can send a note when the person goes, but let the doctors know that, okay, going forward, this is what we're going to try to do. Between so and so time, somebody will bring all the folders that we have to you. It might just be one, it might be three. How do all the professionals agree on the management plan? Are you asking me or him in terms of what that the nurses should? Dr. Grace, can you speak so I don't have to be reading your messages for everyone? Ideally, it's the students on industrial training or clinical posting that send these case files. But like you said, you don't always have students, right? So what do you do when you don't have students? You have to have a plan. So your plan can be, exactly. So your plan can be so how many of you work in your department? Let me ask that. And how far away? I mean, this is breaking the problem into little bits, like it says in what we've just learned. So how far away are you from the doctor's office? Because that seems to be the primary issue. One, how many of you are in your department working? That's my next question. Can you talk to me? Or you still can't unmute? It's quicker than me reading. So you have 2 per shift, okay? How far away is the doctor's office? You say it's far. So is it a 10-minute walking far distance? Is it a 20-minute walking far? I mean, we're trying to problem solve. So be specific. Can you talk? Can you talk to me?
Okay.
How
It's
far is the doctor's office?
okay. So the prosthetics and orthotics unit is kind of new.
Okay.
So the hospital is ideally an orthopedic hospital. So they it's like they got another apartment very close to the hospital for that unit.
So the orthotics is in a different building altogether.
Yes, but it's not too far away, maybe like 2 buildings from the main hospital.
So if you were to walk there, how long would it take you?
Mm, let's say less than 5 minutes. Less
Okay.
than 5 minutes.
So how many patients do you see in your clinic at any one time? Or how often do you book your appointments?
Okay, so our main referral comes from the consultant orthopedic,
Okay.
and so when they do that, the nurses brings the car to us first. while asking patient to wait, depending on how the inflow looks like for that day. So in a day, minimum of say 5 to 6 patients, and when they come, we try to reassess. We do our own assessment again, and
By the way,
sometimes
okay.
sometimes it takes time. So while we are doing that assessment, the other person might be like my superior will be doing the consultation while I'll be working on the cases we already have on ground, while some patients will come in for pickup, of these orthosis devices and educating them on how to use them as well. So sometimes it's really um stressful. One method we have devised was that as the nurses come, before they go, we try to plead with them to wait. Let us quickly, write our case, our own observation, so that they can take it back along with them to the different units we are supposed to refer them to, while you know looking for
Okay.
another time to arrange for them to move back to those units. So when we do that, most times, if the nurses cooperate, we don't have those issues. But in situations where the nurses will be like, I want to go back, I want to go back, there's nothing we can really do, only to, send them to this unit, describe where they go to. And we always have, I think the security always assist us to, mobilize patients, to move them, for those ones that cannot really move. I
Okay.
don't know if you understand what I'm saying.
Yeah, can the security take the chat back?
I
Are
don't
they
know
allowed
if that's
to?
hospital policy, but we've not tried that.
So why don't you ask? So that's the number 2 thing on your list. Ask about if the security are allowed to carry chats, because
Okay.
that's an option. So you're going to have a conversation with both the doctor that you can talk to and the nurse, the head nurse, I think you said, manager, and then ask about the security if they can take the chat. And the other question I was going to ask, so when the doctor refers to you, the nurse brings the chat and the patient.
Yes.
So you need to send the chat back, your response. How soon is that doctor going to see that patient again? Is it right away or is it on another appointment?
Sometimes it's not right away. Sometimes from our units, they go to sometimes the physio unit, sometimes the pharmacy, sometimes even the nursing unit for injection and all of that. So it's not really immediate. But if we have any suggestion on, they are not really in the field, they can just say, okay, I'm suggesting that you do this, but do your assessment. And sometimes we don't align in the same.
So that's what you get back to the doctor.
Yes, that's the only thing that goes back to the doctor. If there's a change of maybe what he's proposing,
Recommendation.
or yes, or what he's recommending.
Okay. So my thing is, from what it's sounding like, and correct me if I'm wrong, it's not that file, there is no urgency for the file to go right back.
There is no real urgency, except maybe on the chart, there are medications too.
So they need to go to pharmacy.
Yes, they need to go to pharmacy, they need to go to the nurses for injection, they need to, sometimes some tests, they need to go to the lab. These are the different units that they can go to from the,
From yours.
yes, from
So
mine.
are other departments having the same problem then?
I think so. I think so. I think so. Because we don't have that health assistant, like somebody rightly said.
Yes.
I think we are all facing these problems, but sometimes, okay, one other constraint we are facing is because how many tertiary universities offers this program. So sometimes for them, they always have somebody coming for IT or posting at every given time. Unlike us that we have to wait for a window of maybe when Futo sends somebody to us, or if the people are even willing to come to the area where the hospital is located. So those are some of the challenges we are facing. But for them, they have consistently, there's somebody always around, a student on posting, a student on IT, and all of that. But the management has advised that we use these students for these purposes too. But we don't have that luxury all the time
Okay.
in our units.
So I think the number 3 thing on your list, I think if the problem is persisting, which it sounds like it is, I think when you or your boss are at the next interdisciplinary meeting and this issue should be brought up, and you're coming from a patient care standpoint.
Yes.
You guys, at any one point, there are only 2 of you attending to everybody that's coming in.
Mm-hmm.
Can the hospital hire a porter? I mean, that's a suggestion you can make? Because you can just put, the nurses will be there, they will answer. They're too busy, they don't have time, and sometimes the nurses cannot wait because they have other places to go.
Yes.
So you are not reporting the nurses, you are stating facts. They're busy, they have other things to go, they can't stand and wait around for you guys. So if you had like a porter or an assistant, whatever they want to call them, then that person could be your legs. I don't know if that has ever been recommended, but I think that would be your number 3 on your list of things. Right? So we've given you three possibilities to address. And let's see if any of them work. They might say there's a financial constraint, but I mean, if you don't ask, you don't know. That's always my policy. Because there is a problem and it's affecting patient care. And that's where we have to keep hammering. It's not that you don't want to walk and take the file. If you didn't have patients, of course you'll take the file. But there are only 2 of you. And most times you have like 3, 4 patients at any one time in your clinic. So one person cannot just stroll off and come back. Again, you are not now giving good patient care to the patients waiting for you to go and come back. So I hope that helps. But thank you. That was a good scenario, a real life scenario, I must say. So these are some of the things that when you have a problem like this, let's not look at the huge problem and say the consultants won't listen. They may not, you're right. But if we don't try, we need to break it into tiny, tiny pieces and see where you can break through. So let's not always be, let's look at the glass as half full, not half empty. That way, let's look for the solutions that will solve the problems. Let this, because sometimes the problems can so overtake us. It makes us immobile. And then nothing changes. And we keep complaining, and they say insanity is when you keep complaining about the same thing, doing the same thing, and expecting a different result. So if let's say, okay, 6 months down the line, we come across this young man again, and we're asking, and he says, actually, plan A didn't work, plan B didn't work, but plan C worked. Yes. That's what you want, is that you keep coming up with solutions till one will work. It will. It's not if maybe one will work. It's just finding the right one. So please, let's all have an attitude of solution. Let the solution be bigger than the problem. Okay? Thank you. That was great. So moving on. So I'm not looking at the chat anymore, guys. I'm back on my PowerPoint, so I can't read. If I see any number on the chat, I'll try and go back, or maybe my co-host can just help me. I don't mind answering questions as we go along. Just put them in the chat, and then we can address them. And if you need to speak, then we can talk about it. So let me go back to where we were. Okay, so now to the question about the research and getting information from patients, etc. Collecting feedback and performance data. Why do we even need to do that? Why bother? It's essential for improving quality and effectiveness of rehabilitation. Effective methods ensure that the data is reliable, it's actionable, so we can act on it, and reflective, so we can look back and say, okay, what did we do wrong? Okay, we don't want to do this, we don't want to do this. This is what we want to do. Of both the patient's experience and your clinical outcomes. So it's not just looking from the patient's point of view, but it's also looking at clinical outcomes. So again, effective methods ensure when we get feedback and performance data, effective methods ensure that the data that we collect is reliable, actionable, and reflects of both the patient's experience and clinical outcomes, so our clinical skills. So some of the methods of gathering this information. So this will help you with research. So you know whether you want to do a questionnaire and all the other choices we'll talk about. But I mean, this is not about research, but these are just ways you can get information. So the first one is patient satisfaction survey. We've all done these, we've all seen these. And the purpose of it is to measure the patient's satisfaction with the service provided. And when we talk about service provision, we're looking at the quality of the care they provide. We're looking at the staff professionalism. And we're looking at the patient's overall experience, which will include things like the waiting, the moving from point A to point B. You know, are you overusing or underusing? When we overuse is where the different people are asking the same questions when the patient has answered it once and it's documented. Everybody after that should go back and read that file. Don't ask the patient again. During the course of the conversation, you can reinforce, or if you have questions, you can then question them. Okay, I saw that you told my colleague that this happened. Was there anything else? For clarity, and sometimes one thing I've learned over my 30-something years of practice, when we do an initial evaluation, we never get the full picture. Sometimes months down the line, patients will come out and tell you something that's really important to their care that maybe they either didn't think about, didn't think it was important, or it didn't even cross their mind at the time of the initial evaluation. So that's why I tell people that I work with that every interaction with a patient is an evaluation. It's a mini evaluation, because they will tell you pertinent information as they become more comfortable with you, as you have that rapport, that communication, that relationship, which is what we all form with the people. Sometimes it's not deep, it's superficial, but you have a relationship with people. So they become more relaxed and they become more trustworthy. They trust you, so they speak more. Okay, so when we look at patient surveys, it can be administered online surveys. Now we thank Google, we have Google Forms. That's one of many online platforms. So I'm not saying that's it, but that definitely makes things easy, because you send the form, they fill it, it comes right back to you. So you know when somebody has filled the form or not. So you have a variety of different online surveys that you can send via email, or if you have a patient portal, after discharge, they can these surveys can be done maybe partway through your sessions or at the end. And you can send them via email. I was going to say via text, but I noticed that the text in Nigeria doesn't take, it won't accept pictures, it won't accept this kind of documents. In different parts of the world, it does. But in Nigeria, I know it doesn't. I think it's called, the regular text is SMS. When you have like a form or pictures, it's MMS. And I don't think we don't have that capability. At least I've never been able to receive any of mine or send any to anyone. But anyway, we have methods that you can use for online surveys. You have paper surveys, which you can distribute at the end of the treatment session or during their follow-up, if they come back for follow-up. Or you can do telephone surveys. This can be conducted by the staff to collect feedback after discharge. So when they call to check that, oh, we're just checking, since your discharge, are you still doing your home program? Blah, blah, blah. We have a little survey. Can I just ask you a few questions? And so on. So these are some of the methods that you can collect information through patient satisfaction surveys. So what do we measure? The key metrics. You have like the Likert scale of rating, which looks at satisfaction with the therapy, effectiveness, waiting time, communication. So it gives you a scale for all of these. Or you can have like open-ended questions. Depending on the type of question, open-ended are good, sometimes they're not good. So you just have to decide based on what the information you're trying to gather, which of these would be your best choice. And then obviously, when we have electronic health record systems, that in itself generates, a lot of them are made to generate reports, and a lot of data information can be collected. So the purpose is to track performance data and clinical outcomes through automated systems, okay? So, what are my methods? So you have data, so you basically, the information is just there, you have to know how to extract it. So this will give you information about the patient's progress, how compliant was the patient, treatment adherence, did they come for their appointments, and outcomes, how number of sessions they attended, and recovery time. How long did you treat a knee patient for? Because it will tell you this, you have your diagnosis, you look at the EMR, okay, this patient started on the 1st of September and they were done by the 31st of October. So you treated that patient for 2 months. And obviously in your discharge summary, you will have whether they met their goals or not. So it will give you information as to average recovery time. Also, another method with the electronic system, record system, is called process mapping. Using the data from your electronic records to analyze treatment pathways and identify areas of inefficiency. So, I mean, this now goes into like the statistical part of it, which I'm not really going to delve into, but just know that using the electronic record system, these are some of the ways not only that we can get information, but the information can be analyzed in some of the more robust electronic record systems. Metrics, the key metrics, it will give the information you'll get from it. It gives you treatment completion rate, adherence to the care plan, and trends in patient outcomes. So recovery time and how well they return to function. When we're doing in rehabilitation, let me use that word, that's what we are doing. When we do rehabilitation, there's a whole team. And the goal of every single one of that team is return to function. I mean, that is the bottom line, or return to function within the patient's limitations. So this should always be a key focus in when we see these clients or patients. Then you have clinical outcomes. So the purpose of this is to monitor the patient's progress throughout the rehabilitation process and assess treatment effectiveness. This can be done through functional outcome measures. We have standardized tools like the functional FIM, I can never remember, functional, just give me a minute. And then you have the Bathel. There are many, we have many different tools that we use for, and for physiotherapy, we have a lot, sometimes even just based on the body part that you're treating. So, but we have all these functional assessments that we use to assess what the patient is likelihood to, like for falls or for independence. So you can use all those tools to give you an idea or even a baseline of where, most of them give you scores that you can then compare periodically. So they help to assess the improvements in mobility, self-care, and the patient's functional ability. So functional independent measures will help to give you all this information from when we're looking at clinical, when we're tracking clinically, is these tests that we do. We have pain scores, we have, for like kids, you have the Bartel is an outcome measure, you have the Minnesota is an outcome measure. I mean, so like I said, for every area that we see, ages and stages, it's more of a screening tool, but still gives you scores at different ages to see how the patient is doing. So we have all these functional measures that we can use, and I'm sure each component of rehabilitation, they all have theirs. Also patient-reported outcome measures. So these are questionnaires asking the patient to evaluate their own health and functional ability. And this can improve things like their pain level, their mobility level, and their mental well-being. Therapist assessments. These can periodic evaluations by therapists based on clinical criteria and observation. So like I said, I always go with the opinion that every visit is a mini assessment. I mean, yes, we do an initial evaluation, and typically after, depending where you're practicing, between 8 visits to 12 visits, people do a reassessment. And one of the things it said about when we were looking at methodology is that continual process. You monitor what you're doing continuously. If you've seen a patient 8 times, you've given them a program to do. After 8 times, nothing has changed. What do? You have to go back. Change what you're doing, because you can't give them the same thing. It hasn't worked for 8 visits. You're not going to wait another 8. So part of the consistent, repeated reassessments and checking is to improve what we're doing. So some of the metrics that we look for is the improvement in functional scores. So the scoring should improve. So for example, we have the TUG, which is a stand up and go test that assesses a patient's risk for falling. The longer they take to do the test, the higher their risk of falls. As they become more agile, the number of minutes or seconds it takes them to perform the task reduces. So that would be a functional score that we would look at. Okay, when we first saw the patient, their tug was 2 minutes. Now it's 30 seconds. So that's what we're looking at to monitor and to track the clinical outcomes of what we're doing. The time taken to reach the rehab goals, the pain reduction and improvement in quality of life. So these are the things we're looking at as markers of outcomes, okay? Another form of collecting data is real-time feedback kiosks. I mean, I don't know if anywhere has this in Nigeria. Captures immediate feedback from patients during or after therapy sessions. I know a facility that they have a tablet the first time the patient comes, theirs is based on what diagnosis. So if it's a shoulder patient, they'll get the questionnaire for the shoulder, and it basically gives them a score of how they're doing. The patient they sit down for like 3 minutes, fill out the information on a tablet, turn it in. And every 8 or 12, depending who's paying, because I know in America, you have Medicaid, you have private insurance, you have the VA, which is Veterans Affairs, who provide medical for people who've been in the services. So you have different paying sources. So each one decides how often it has to be done. But basically, each clinic will do it at the initial, and they'll do it maybe every 12 or 8 visits, and it's done till the patient is discharged. And that way you have a digital, and immediately they fill it in, it goes into the AMR. So it goes into the electronic records and you can pull it up right away. You have touch screen devices, which are placed in waiting areas. You've seen that where you go through somewhere and it says, press if you're smiley face, unhappy, or there are normally 3. If you've used this service, press if you're happy. So you have touch screen devices that people use for this as well, that can be in the waiting area or at the exit to collect a quick feedback on staff interaction, treatment quality, and the environment. And these things don't have to be long. They don't have to be long. They can be few questions that the patient answers, and depending on the tool that's being used to assess them will depend on whether it's a yes or no, or it's a graded response. So for the touch screen, you're looking at the star rating, because sometimes it will give you 5 stars. We all buy, if you go on Amazon, it will say rate this product. Jumia will send you, please rate this product. And you can do 1 star to 5 stars. So you have the star rating system, and you can do that for each question. So it's quick. Waiting, were you happy with your waiting time? 1 to 5 stars. We do it when you do Bolt or Uber. They will send you to rate your driver. Staff attitude. Free text comments for detailed insights. So sometimes you can do this question and answer via text, okay, or written. They'll send you a text, or they'll send you an email or a message. So these are the ways for collecting real time, that immediately they send it, you get it, okay? The next one is you can collect data through focus groups and patient interviews. These are a little bit more in depth, and it gives you a qualitative insight into the patient's experience and perception of care. You will have small group discussions with patients led by a moderator who will explore detailed feedback on specific aspects. You'll ask them, how was your therapy? How is your communication with the staff? And they will have a discussion. It's more of a discussion, not a yes and no take question. In-depth interviews are typically one-on-one. So for the group interviews, it can either be focus groups. Focus means a group of people, or it can be one-on-one. With selected patients to gather detailed experiences and suggestions for improvement. So These ones a little bit more time consuming, and you really have to make time out to do these ones. What we're looking at is the themes and patterns in patient satisfaction, concerns and suggestions. So, this is information you're going to, okay, so you waited so long. How do you think we can do it better? What do you suggest? If you were running this place, how would you do this better? So that's from a one-on-one or focus group discussion. And then it'll give you detailed feedback on care delivery processes and interpersonal relationships. So the person might tell you, I came in, the therapist barely greeted me. They called me by name. They took me in, gave me exercises to do. They walked away. Then they came back, told me to do this. I really didn't feel like I had a discussion that the patient, that the therapist really saw me. I've heard that expression before from a patient. The therapist didn't see me. They literally, it was just, this was my number 2 patient on my list. So with these kinds of interviews, that's the kind of information you can't get that information on. How was your experience with the staff? Was it good, from good to bad and in between? But when you have a discussion, they can give you this kind of feedback. Or a patient says, no, I don't want therapist A, I want therapist B. And it'll be like, so why? Why do you want, why do you, well, that the therapist A that I prefer, actually, I like the way they interacted with me. They talked to me. We had a good conversation. It's not that the 2 therapists did different things. They may have done exactly the same treatment. But just because that one person saw the patient as a person and interacted with them, they felt like, yes, they had individualized care. The therapist really engaged with them. And that's all patients. I mean, I always tell, from the physical therapy standpoint, I tell people that I work with that half of our job is communication. When you have a good rapport with the patient and you talk to them, you educate them, you explain things to them, before you even lay hands on them, they're halfway better. So that, I cannot take away too much from that piece. Some of us tend to talk too much. I know I'm guilty. I'm the first one to raise my hand, but I think I would rather talk too much than not enough, because then the patient leaves not wanting to come back. But it helps you gain. And when you are in a setting where people are dissatisfied, ask them why. Don't tell them, but we're too busy. Please, we have enough patients. They can go. No. That one patient can give that whole department a very bad name, because our best form of referral is word of mouth. Word of mouth. So when a patient, in my arena, when a patient says, I don't want therapist A, I want therapist B, my first question is, what was wrong? No, I don't say what was wrong. My question is, what didn't they do that you wanted done? Because I want to establish, was this a skills issue? Is it that my therapist didn't know what they were doing? Or is it just that my chemistry didn't blend with that person, and that happens all the time? No, I take that back. It doesn't happen all the time. It happens that we meet people that, I always say my karma didn't blend with their own. That can happen in life. So sometimes people just want a different person because they just feel that their karmas blend. I don't know karma, I don't know what other word to use, but their aura mixes with that person's own much better. So sometimes it's as simple as that. And if that's the case, I don't mind changing therapists. But if you're just giving me some flimsy excuse, then it's different. Or if my therapist didn't do the right thing, then again, we have to put things in place to rectify that problem. Benchmarking. Again, we looked at benchmarking when we looked at methodologies, okay? So you can collect data the same against this way as well, where you're comparing industries. You compare performance data against industry standards or best practice to identify areas that you need to improve. This is where making the data available and transparent helps the whole industry. Because if we all were keeping all our data to ourselves, nobody will improve except you will improve in that area that you're looking at. I will improve in the area that I'm looking at. But when we share information, it helps best practice and we know where we need to improve. The way you can collect this information is doing audits. You can do an external audit whereby you're engaging a third party to evaluate performance matrix such as patient outcomes, efficiency, your compliance with their standards, or by participation in quality initiatives where you join a national or international program, benchmark program, to compare performance against similar rehab centers. So it can be internal where you have an audit, or it can be basically external where you are joining other national or international programs, benchmarking programs, to compare and contrast. So, okay, you're doing this, we're doing this, how can we, okay, that's a good idea. We can implement that piece into ours. And so sharing of ideas, that's how programs grow and that's how we progress. So the key metrics that are measured, the performance against national averages. So you look at the average length of stay in a hospital, patient satisfaction scores in the hospital in Kaduna compared to the hospital in Jos, compared to the hospital in Port Harcourt, compared to the hospital in Lagos, so you all compare your numbers together. Okay, and then compliance with accredited standards. So that's why there's an accredited board. So these are the standards that have been put in place. Are we all following those standards? Because when we have a benchmark, when we have a standard, it keeps everything standardized and we expect the same results. Not exactly the same, but you know that if I do X number of visits, doing X number of treatments, there is a big chance that this patient should be able to do this, this, and this. Okay, so it helps with standardization. Okay, now something else I was going to say about this. Okay, if it comes to me, I'll come back to it. And then the other way of gathering information is through staff feedback and peer reviews. Purpose, collection of feedback from the staff and clinicians to identify process inefficiencies and opportunities for improvement. We should never be afraid of criticism. Criticism makes us better. And the only thing I can say, we're talking about communication skills here, or we have quite a bit. And I think it's important. What you say matters, how you say it matters. You know, I teach classes about verbal communication, verbal and nonverbal. And I always tell people that your nonverbal communication speaks louder than your verbal communication. Our body language speaks a much larger, makes a loud noise compared to what comes out of our mouth. And so how we say things matter. You can tell somebody hello, and it can be a greeting, and you can tell them the very same hello, but it can be a curse, depending your tone of voice and your body language. So when we talk about feedback and we talk about peer review, okay, before I jump into that, so we collect data through staff surveys. It can be anonymous, where you are asked to say there are 5 staff members. So each person will get to do the review on somebody, but when the review is written, the person who does the review will not identify themselves, but the person will get the feedback. So it's anonymous. So you don't know who reviewed you. Okay. So anonymous surveys to gather staff insights on workflow, patient care processes, and areas that require improvement. So not only can you do the anonymous with peer review, you can also do the anonymous with, you know, people will say, I'm not going to give my opinion because if the hospital knows it's me that said that, I'll lose my job. So it can be anonymous. Surveys can be anonymous, okay? And when you're talking about peer review, most times peer reviews can be anonymous if the supervisor wants it to be, but sometimes it's they can make it anonymous if they feel that there's some antagonism between this, if the group of staff they're working with, there is there's discontent. So then you can make it anonymous. But it's not a witch hunt. Please get me, let's, when we look at peer review, is that we're reviewing our peers to see what are they doing well, what are they not doing well, what could they do better. Regular evaluations of staff performance through observation or case reviews by colleagues. And one thing I want to say, I'm sure there are many on this group who are supervisors. Please, let's not use our reviews as punishment. If the staff is not performing, they're not performing. That needs to be addressed. But let's not, it's not a threat. It's a peer review or your what's it called? When you do your assessment at the end, your staff assessment, which I do. Oh, let me. Okay, all my words are disappearing. It'll come back to me. But yeah, so basically you're evaluating the staff's performance through what you've seen, through reviewing their cases, and also comments from other staff. So, and I think it's a healthy thing to do. None of us is perfect. And I think if we don't take criticism, we can never improve. And we as the person doing the review, be objective. You must be objective. So it's not like saying, oh, your peer review is the person wears red hair to work. That has nothing to do with their performance. It has something to do with their appearance. If your dress code says no red hair, so the red hair is not the issue, is what is your dress code? Then you can address it. So be objective, be factual. Okay. Staff meetings is another way, which is more of an open forum where therapists, nurses, and other staff can discuss challenges, share ideas for improving quality of care. So the same thing with, those are how you go about getting the information. What do you look at to assess the information? You look at employee satisfaction with the workflow. You look at identifying process bottlenecks, and you look at staff suggestions for patient care improvement. So that's the information you're going to glean from the above in terms of for both your employee and the provision of care for the staff, for the patients, I'm sorry. Okay, so another way is observation and time studies. These assess the efficiency of rehab processes by observing real-time operations. By observing real-time operations. What does that mean? It assesses the efficiency of rehabilitation processes by observing what you're doing. So the way the information is collected, the method is direct observation. So you have a supervisor or supervisors, sorry, who oversee what you're doing, or process improvement teams that observe staff's workflow, treatment sessions, and patients' interactions to identify efficiencies. So this is basically just somebody watching you do your work. Okay, and then you have time motion studies, which track the time taken for specific activities, such as patient intake, treatment sessions, or administrative tasks to identify areas for optimization. This will help you with time spent on direct patient care versus administrative tasks or workflow bottlenecks and delays. And when this information is collected, when we talk about, there's some people who are in jobs who the job is split into both direct care and administration. So they have to do both. So knowing that, okay, when if I have to do monitoring, this, that, and this, it takes me so many hours. If I need to see a patient and do my documentation, it takes me so much amount of time. So when an employer says to you, your job involves 40% administration and 60% clinicals, it gives you an idea that, okay, I can't be seeing patients all day. I have to only see X number of patients a day to be able to give me X number of hours to do my administrative work. So these are ways that it can also help you track your time and prevent. You see so many patients and you don't have time to do your admin, but admin needs to be done because the department needs to be run, but the employer wants you to do patient care as well. So it's sometimes a fine balance in trying to integrate the two. When we look at direct, okay, I remember what I was going to say about direct supervision. Also, part of that, when we're timing what somebody's doing, when we see patients, and say, for example, you just start a practice. I'll give you the scenario we had. You start a practice, you're new, maybe you're seeing 2 or 3 patients a day. So you end up spending sometimes 2 hours with one patient because you don't have another patient coming in, or your schedule is light for that day. And you have a 10 o'clock, you have a 12 o'clock. So you don't have a patient in between. And you spend 2 hours with that patient. Okay, the clinic policy is 50 minutes and then 10 minutes for documentation. Some hospitals give you 20 minutes per patient. So in an hour, you must see 3 patients. So when you don't have another appointment and you keep that patient in for 2 hours, and then you become busy and you now want to implement your clinic procedure, which is 50 minutes, what do you think that patient is going to say? You're going to create a dissatisfied patient because now that patient thinks, oh, now that you're busy, you don't have time for me. But really, your policy is 1 hour. But because you've let yourself slide, because, oh, nobody's coming in, okay, I can just continue. In that patient's mind, therapy should last for 2 hours. So now you've created a problem you need to go back and fix, and it is always difficult to fix it. So what I always say with clinics, anywhere you're working, start as you mean to go on and start like you're really busy, even if you're not. So if your time is 20 minutes with a patient, even if that's the only patient you have the whole day, do your 20 minutes. Because when you do get busy, which you will, that patient is going to feel as if you're not giving them proper care. So all these things, when we do all these methodologies and we gather all this data, it's for our own good. let's not collect the data and then continue doing our old habits, because it makes us more efficient. So when you do become busy, you don't have to reinvent the wheel. You don't have to change anything you're doing. You can just provide timely patient care, adequate, not even adequate. I mean, you're working in your professional capacity and your patient is getting better, patient is coming in for the time that is allocated, and you are providing services, evidence-based services, where the patient is getting optimal outcomes. So please, when we're looking at our time, these are some of the things we need to take into consideration. So those are some of the methods that we can collect information, that we can also, how we extract the data, what information do we extract? Those are your key matrix. What information do we extract from them? And that is what we analyze now to help us be able to provide quality, improved care that we're constantly improving, because we're constantly assessing and reviewing what we're doing. Okay, so the next part of this is project management. To do all these things that we're talking about is good. I'm sure some of you are saying, who has time for all of this? Who is going to manage all of this? Who's going to be doing all of this? Well, when we do quality control, this is it. I mean, the big organizations have quality control departments that take care of this, but we as professionals have to be able to weigh in, because nobody is going to improve your profession other than you. Nobody. You might request for help from your organization, but you have to be the project manager. I'm saying that loosely, but I mean, these are things that so effective project management, because these are projects. This is not something, most people don't employ you to come and do this. They come and employ you to do patient care. But what we're discovering, for us to provide quality patient care, we need to do all of the above to make sure we're checking ourselves, we're monitoring, we're updating, we're correcting, we're being innovative. So effective project management ensures that the QI initiatives are organized, have clear goals, and are implemented on time and within budget. Like I said, these things take, if you want to do a questionnaire, you have to print them. Somebody has to sit down, come up with the questions. So there's time involved in all of these, in QI. I mean, it's not going to just happen by itself. It's not. So that's the importance of being able to have somebody who can manage all of these things. So project management now, we've talked about what we have to do. How do we manage it? Okay, so defining the scope and defining the project scope and objectives. So you want to identify the problem. So this is project management, and you have project managing, okay, let me have some. You have project management in construction, you have project management in healthcare. So the first thing we do, we've been talking about that already. You want to identify your problem. Okay, you want to establish specific objective, so you have SMART goals. Let's start there. You identify your problems and you set objectives. So you have your measurable goals, your achievable goals, not goals, sorry. You have, when you identify your objectives, they should be specific, measurable, achievable, relevant, and time-bound. And the goals for then you say, once you have your objectives, you set your goals. Okay, so decrease wait time by 20% in 6 months. So it's very specific. Your goal is the project you're working on is decreasing time, is specific. How are you going to measure it? 20%. It should be down by 20%. Is it relevant? Yes. We don't want patients waiting. Time bound, 6 months. You're going to do this in 6 months. And it is achievable. Okay. So who are you going to engage? You want to identify the stakeholders. So they're going to involve your patients who come for service, your staff who administer service, your management who control everything, and to understand their needs and expectations. So you have to know what each person's responsibility is going to be. So you've defined your scope and your objectives. So how do you now develop? The next step is to develop a project plan. Okay. In doing this, you want to create, it's like you have a charter. You create a document that outlines all of what we've discussed above. Your purpose, your scope, who the key holders are, and your timeline. So you establish your charter. That's called a charter. Okay. Anybody that's done like leadership training, any of those things, this is all part of when you do leadership training, because leadership running as health professionals, we have to be able to do both. We can't do just clinicals. We have to do the administrative side and project management and all of these stuff that we've been talking about to improve our professionalism come hand in hand. Okay, so you state your charter. So the next step is develop a project plan. The steps are you state your charter. So what you have your SMART goals, your timeline. You do work breakdown structure. Break the project into small, manageable, deliverable pieces. That's why when we were talking to, okay, I've removed the list. Is it Umuna? I was asking, okay, how far is the doctor's office? How many of you are in the clinic? How many patients do you see? I mean, how long is so break the task. That's what I was trying to do, to give you an example of this. I was trying to break down the issue he brought up into little bits. Let's start with little bits. Because it's like, if you said to go, I'm going to run a marathon by next month. Is that doable? Absolutely. Well, let me speak for myself. Absolutely not. Because I can't run a mile. I can walk a mile, but I can't run a mile. So why would I set a goal to run 26 miles in a month? So what I would say is my goal at the end of the year is to run 26 miles. I want to be, because I know it takes a lot of training. I'm a physical therapist. I know it takes a lot of training. If I'm not running already and I want to go run, not only do I want to run, but I want to run 26 miles, I know I'm giving myself a year. So when I set my SMART goals, it's like by the end of my first month, I need to be able to walk 10 miles a day. Walk. I haven't started running yet. And then maybe the following goal will be out of that 10 miles, I start jogging 25% of the time. So you have to break it down into pieces that you can do. It might be, okay, I'm going to jog for 1 minute, walk for 3 minutes, jog for 1 minute, walk for 3 minutes. And then my next goal would be jog for 5 minutes, walk for 10 minutes, and so on. So that's what the work breakdown structure looks like. You're breaking down the project into tiny pieces that you can deliver. The timeline and milestones. Develop Gantt charts is a chart that basically allows you to do small pieces when you set goals, let me finish this. Develop a Gantt chart or similar tool to outline the project schedule. The project schedule, including key milestones and deadlines. So that is what the chart does. Gives you small incremental. So you don't set yourself up for failure. Okay. So that's what small pieces, small goals. And then you also want to have your timeline, which we've talked about, and then your budget. Estimate the cost associated with the project, including resources, training, and any technology or tools you will need. Let's take my running a marathon example. Okay, I'm going to need good training shoes. So my budget is going to include running shoes. It's going to include a timer. It's probably going to include a blood pressure cuff. It's probably because I want to monitor my vital signs. So you're going to have running clothes depending on the weather. If it's cold, you're going to need warmer clothes. If it's hot, you're going to need something cooler. So you have to look at the whole project visualization. You look at it and you say, okay, what are some of the things that I need to execute this project? And that's where it comes in. And what the Gantt does too is gives you can draw like charts. So visualization. It gives you charts and graphs that you can see how you're progressing. Okay. And then the next one is to assemble the team. Who is your project manager? Assign a project manager who will oversee this initiative. And then you have your team members. So you want a multidisciplinary team that will include clinicians, obviously, administrators. You're going to need IT, and you need quality improvement specialists if this is going to be done right, because you want all your data uploaded onto the computer. So and if possible, most of your questionnaires and things, if it's electronic, it's easier to do to analyze your data. So you need somebody in IT. Okay, so you want to make sure you have the right team of people to execute the program. And then each person in that team must know their rules and their role and responsibility. Each person's role must be clearly defined. Each person's responsibilities should be clearly defined to ensure accountability and effective collaboration. If you just leave it, okay, this is the project, this is what we want to do. Okay, team, this is who you are, and you walk away. Okay, so the right hand will think the left hand is doing it, and the left hand will think the right hand is doing it, and guess what? Nothing gets done. So everybody's roles and responsibilities must be clearly stated. And you should have an order. If this is what you do, if it fails, this is the next step, so on and so clear, defined roles. And once you have your team, you now implement. Okay? You want to develop your action plans. Remember, you've broken it down into pieces. So now you want to get your action plan, create detailed action plan for each task that we've specified. So from that, you know who is responsible. It goes back to your role and responsibility. And they know what needs to be done. And you have your SMART, you have your timeline. So nobody has to guess at what they need to do. When it comes to implementation, you have your plan, you create your tasks, you know who's responsible, they know what needs to be done, and they know the timeline. Training and resources is important because it provides the necessary training and resources to the team to support the implementation. of new practices and technology. So you might have an IT person on that team, but everybody has a computer. Everybody has to upload their information. So you might need to do training on the computer system or programs that you're going to be using for this project. So training is very important to make sure you've given them a role, you've given them a responsibility, make sure they have the knowledge to execute it. So that's where your training and resources comes into play. And finally, my best word, I love this word, communication, communication, communication. Establish regular communication channels and updates to keep stakeholders informed about progress and changes. So we have people who are stakeholders. We've established that in this whole project. They must constantly be kept informed, good, bad, or ugly. They need to know if you're not meeting timelines. Because guess what? When you don't meet timelines, it affects the budget. And if these are your stakeholders, budget is very important to them. So you must be able to communicate and update your stakeholders at regular intervals. It's not when everything falls apart. They will say, oh, well, actually, we didn't have enough money, so we weren't able to buy this, we weren't able to do this, and these people took too long. Did you tell anybody? Did you try to fix it when it first happened? Don't wait till the day you're supposed to deliver the project and you don't, and then come up with all these excuses. So communication at every step of the way is very critical. Same with when we do patient care. Tell the patient what you expect. Where are we going? They will say, okay, I have patients. I say, okay, what was the goal the last therapist was working on? I don't know. They didn't tell me. So how do you expect them to do home program when they don't know what they're working on? When I tell a patient, okay, you have a shoulder problem, this is what I sometimes I give them, I call it anatomy 101. I explain what's going on. And I say to them, okay, this exercise does this one does this. And then I try and link it to function. Okay, if you're not able to do this, you can't scratch your back, you can't do your bra, or you can't do a zipper, or you can't put your hand behind your back. If you want to reach for something and you're falling, your hand won't go back to protect you. When they see what their oh gosh, I've forgotten the word. When they come to you and whatever function they have lost, when they see the ramifications of gaining it back, they will be on board. They will be stakeholders in that process because they want to get better. They want to be able to do the things they were doing. They knew they could do it before and they can't do it now, but sometimes they can't correlate that injury. How can me just hurting my shoulder stop me from not being able to walk? Sometimes they hang the shoulder down and it's just throbbing. So when you explain and you give them an insight, oh, is that why? No wonder. That's why this place here is hurting, because this one and this one are connected. They're with you. And the difference you see in your outcomes will be immense. So communication, I mean, I'm giving you different examples in different arenas because I think it is key for us to be able to communicate, not just in our workspace, by the way, in all aspects of life, but that's not what we're here for. Anyway, so the next part of project management is monitor and control. Okay, performance matrix define your key performance indicators. Okay, what are your KPIs and metrics to track the progress towards those goals? So when we look at outcome studies, they will give us numbers each time. Those are your key performance indicators. Okay, the patient went from normal is 0 to 3. Okay, they're at a 20. Okay, the next time you assess them, they came to a 15. After that, they came to a 10. Then they went back to a 15. What happened? You need to go in, intervene, adjust, review what is going on. Okay, so regular reviews are very important. Conduct them to help you review the progress and to meeting to assess the status of the project. I'm mixing project and patients, so don't mind me. But anyway, but yeah, sometimes our project is our patient. But so these are the things you want to address any issues and adjust your plan accordingly. Okay, so if it was a budgetary thing, okay, you came back and said, look, we budgeted $50,000 naira for this. Now, with overnight, it went from 50 to 70. But your stakeholders need to know that information immediately, so they can say, okay, can we afford to increase the budget by 20,000, or do we have to pivot and do something else? So regular reviews will help you do that. And then risk management, you identify potential risks and develop mitigating strategies to address them. So like, because based in implementation and resistance to change, you might go into a department that they ask you, okay, we want to increase patient load, we want to decrease the time staff are sitting around because patients are not here. Well, you might go into that department and those staff are quite happy to sit around when patients are not around. They are happy with the caseload. So when you go in there and your job, you've been tasked to increase revenue, i.e. increase the number of patients, you are going to meet with a lot of resistance. So you now need to know how to navigate around those issues. Again, I will say this, communication is key. It's like, okay, guys, yes, it's nice not to have the patients, but guess what? This department is not paying for itself. And if it's not paying for itself, the management is going to shut us down in 6 months. So do you guys want your jobs? If it's a yes, then fine, let's get on board. This is how we need to go. And then your project management kicks in. Okay, so then you've shown them the risk. So now, these are the risks. These are what the strategies we need to put in to mitigate those risks. Let's get this plan in motion. So sometimes you have to navigate around resistance, and how you do it, how you communicate that information will be how easy or difficult it is to navigate. And then you want to evaluate and adjust, okay? Data collection, you collect and analyze the data to the project's performance and outcomes, okay? You want to get feedback. Sorry, where am I? Yeah, feedback, to gather feedback from patients, staff, and other stakeholders to assess the effectiveness of what you've implemented. So you've set up your program. Let me just review. You've got your plan with the project management. You define your problem. Okay, you develop a plan. You assemble your team. You implement the improvement strategies. Okay, you monitor and you control what's going on. Okay, and after that, you now want to evaluate and adjust. So you collect data to analyze the performance of the project and what your outcome measures have been. Okay, you then now want to get feedback. Okay, get feedback from the patients, from the staff, from other stakeholders to assess, okay, let's take the example of increasing revenue and patient care, number of patients and reducing time spent, unproductive time spent. So you now want to look, okay, what's the feedback? Patients, have we increased the number of patients? Okay, each staff, how many patients have we seen? How much time are they spending on patient care? How much downtime do they still have? And in your evaluation too, you want to look at outcomes. Are patients still getting better? And all of those things. So you've evaluated, and then you say, okay, based on these results, what necessary changes or adjustments do we need to make to the strategy in order to improve quality of care? So if by saying we've improved revenue, yes, we've improved patients, the staff are now fully productive, okay, we can run with this plan. So we're going to still implement all what we did before. Okay, we're going to see how we do in 3 months. And then you're going to come back. All these things need to be documented. Okay? So you're going to document and report. In your documentation, you want to keep detailed records of the processes, decisions, and outcomes, because that's what you're going to be going back to review. Documentation, I don't know why I heard this saying before, but I know very much it's very much an American saying, if you didn't write it, you didn't do it. So please document everything we do. We need to document. So you document all your processes, decisions, and outcomes. You then come up with a final report that summarizes the achievements. So what you gain, what the challenges were, and what you could have done better, the lessons you've learned. So those all go in your final report. Okay, so you want to document your achievements, your challenges, and what you've learned from working on the project. And then presentation. That information now needs to be shared with your stakeholders who might be, the leadership of the organization. And of course, you want to highlight the success and also areas that need improvement. Because sometimes you do these things because you want them to increase your budget. So if they had come to you and said, okay, we're not increasing your budget, you guys, you have 10 therapists, you're not seeing enough patients, the money that's coming in doesn't even cover what we're spending on the department every month. So you now implement this plan to increase patient load and increase in, not inventory, increase the money you make in the clinic. my brain. Okay, so increase income and increase patient load. So you are able to do that. And with your same number of staff, you've decreased downtime. And now, whereby your department was making 10,000 a month, but the hospital was spending 15,000 running your department with salaries. I'm just using that figure as an example, please, for ease of my own brain. So you made 10,000, the department, the management is spending 15,000 to basically run that department between salaries, durable medical equipment, consumables, and all of that. So they're spending 15,000. So you implement this plan. And at the end of the 3 months, I can't remember if what that timeline was. Okay, my running was a year. Okay, so, but for this one, for this increased revenue, thank you, that's what I was trying to remember. They gave you 3 months. This plan, the timeline was 3 months. At the end of that 3 months, your revenue now went to 30,000. So now you can say, okay, look, we're making 30,000. You're spending 15,000. We're making a profit of 15,000. Now you can request anything because you're making money for the hospital. So you want to make that presentation to highlight your successes. And now you're going to say, okay, we've been able to do this. We've managed with what we have. But if we have A, B, and C, it's going to make us better. And we're going to be able to increase what we're doing even more. So not only are you saying, yes, we did well, but okay, these are some of the areas that we need to improve on. Obviously, any improvement takes money. So now we've made the money, and you can see that we have the potential to make the money. Now you want to say, okay, these are some of the things we need for improvement. So that is a benefit of documentation. And then the next part is sustained improvement. Okay, so we've done all this. We're making money. Now we want to keep making money. We want to keep providing better outcomes. We want that the vision of that department is that anybody that needs physiotherapy, this is where they want to come to first of all before they go anywhere else. So you want to maintain that improvement. You want to sustain it and keep getting better. So standardize. You have to have standardization. Okay, you want to develop and implement standardized procedures and protocols based on all the successful strategies that you have implemented that made you go from 10,000 to 30,000. Okay, so you want to standardize your practice. Okay, patients come in, it takes them 2 minutes to register, the therapist is waiting, they go straight into the room, the therapist is efficient, she's like, okay, you came in, how are you doing, da da da. So that's all. So in your part of all your processes above, one of the things that you implemented was that I said that every visit is a mini assessment. So we're able to track the patient's assessment as they go along. So the therapist goes in, tracks, you're doing this, this is this, okay, we're going to change this, we're going to do this. They do something else, the patient is even better. So you want to standardize those practices so that no matter who is doing it, so if your whole team changes, your income doesn't drop to 10K again. So you have things in place that you can implement. I'm going to say one thing here. This is a presentation of what we should be doing. There are places that do this all the time. That's why they're efficient. People will look at this and say, this is too much work. It might be to start, and some of us need to start. Like we were problem solving for the hospital, the orthotist, that just trying to get the patient's case note from them to the doctor. Sometimes the problems just seem unsurmountable. But if we can break them down into little pieces, sometimes the next thing you know, you're like, this was a problem. Why? But because we were looking at the huge mountain and we didn't try and, walk on the grass first before we started climbing uphill. So if we have standardized practices, everybody is following that framework, you are able to sustain it. But if everybody new comes and they're doing something different, you can't sustain your improvement because you've now moved away from the plan. You've deviated from this plan. Okay? So the next thing is ongoing monitoring. You want to continue to monitor the performance of new processes and make adjustments as necessary. So whilst you're still doing it, you're still assessing, you're still modifying one thing at a time. You don't want to change everything all at once because then you don't know what was working and what wasn't. You may have thrown out what was working along with what was not working. So it's little pieces. You identify this problem, fix this one. You identify this one, fix this one. Don't say, okay, this thing is not working. Let's change. Okay? So ongoing monitoring allows you to make ongoing adjustments as needed. And then continuous improvement. It fosters a culture of continuous improvement to help encourage regular feedback, ongoing training, and periodic reviews. So when we continually improve ourselves, we're doing continuing assessments, we're training ourselves, we're doing ongoing training, and we're reviewing what we're doing. Is this still working? Okay, we're doing this test. Oh, I read in a new research, this test might be better than this. We can try it, see if it works. If it doesn't work, we'll go back to the old one. So you're continuously training, you're getting regular feedback, and you're reviewing what you are doing. Okay, so an example of this, reducing hospital readmission rates. The problem was high readmission rates for heart failure patients. Okay, The goal was to reduce admission rates by 15% within 6 months. So the stakeholders in this project were the doctors, the nurses, coordinators, IT staff, and the patients. The tools that they were going to use to assess the data was the root cause analysis to identify reasons for readmission, the PDSA cycle to implement and test the new discharge procedure that they were going to come up with. And then the outcomes was continuous tracking of readmission rates, feedback from patients, and process refinements based on performance data. So when they assess this, they obviously, when the patient is going home, for all we know, they were not, typically when a patient is being discharged, the nurse will sit with the patient and say, okay, these are your medications. This is how you need to take them. You need to follow up with us in 2 weeks. You need to make sure you don't do this, you don't do that, you do this, you do this, and the other. So for all we know, that what was happening is they were giving the patient a bag with their medication, giving them the appointment to come back, and sent on their way. So they went home not knowing how to manage their medication. They had no do's and don'ts. If they've had heart failure, they may have told them, there are things you cannot eat, there are things you can eat. So if they were giving none of that information at discharge, they might easily fall ill, maybe even just from not taking their medication. So that's why they tested new discharge procedures. How are we discharging these patients? It might include a more thorough explanation at discharge from the nurse. It might include a follow-up visit in the patient's home, in their own natural environment, to say, okay, you go in, you see, when you go to patients' homes, you really see what they are not doing. Having been a therapist that's done a lot of home care, trust me, when you go to patients' home, you get the real picture, the one that you don't see when they come to you. So it might include something like that, going to the patient's home. For all you know, the patient lives on snacks. There's no healthy eating because he can't stand in the kitchen to cook. He may not even have gas to cook. I mean, little things, I'm saying little, they're not little, but things like this, when you now go to the home, you will understand why they cannot follow through with the discharge instructions they were given in hospital. So now that's where social services comes into play. And they're now able to implement certain things for these patients. In America, they have services where they can deliver 1 meal a day to a patient to make sure they eat a healthy meal. So when you're looking at a case study of improvement, these are some of the things that you can tease out when you now go and you assess the problem. And then you can implement your changes and see if those work. So that's basically, I'm trying to relate the project management to how we practice in the healthcare arena, in the rehabilitation arena. But yeah, I mean, they do this in industry. We're an industry too. It's just we're in the health industry. So we need to be able to do this. And sometimes I say to patients, we only have information that you give us. We can only help you based on what you tell us. And that's where that communication piece again comes into play. When they feel comfortable with you, you will be surprised what they will tell. I'm sure people can tell a whole story on this group about when patients are comfortable, it's like TMI, too much information. But that's where you want to get to help somebody. We are trying to change lives and improve function, their functional day-to-day activity. If we don't know what they do from day to day, how can we implement any change? We cannot. And what they'll do is you'll give them advice, they'll shake their head and say yes, walk out your office and leave the advice with you. And you'll wonder why they're not meeting your outcomes. So we need to be able to implement and refine what we're doing based on feedback from them. Because it's what they're doing that we're trying to enhance, let me not say change, enhance to get better outcomes. Okay. Okay, so the next part of this is data collection, analysis, and reporting. This is where there's now a lot of overlap on, this is kind of summarizing some of what we've talked about. So data collection. So does anybody have any questions before we go on to this? Any scenarios that you can share? Because sometimes when you hear real life, like one of them is real life, your real life things that happen, it helps put things in perspective. And one thing I can say is sometimes if you have a problem in your facility, you might think you're the only one, but you're not. Maybe somebody else is having the same issue, and by sharing it, we can, like we just did with this, with the other case, is give ideas. Nothing is absolute. You know, nothing is absolute. So we might need to, so that's why I'm asking, does anybody else have any scenario that we can discuss? I mean, we've talked about how we gather information now. Before we get into the data analytics side of it, which is not my strong suite, but anyway, I'll do my best. Some people go to college for data analytics. But so yeah, so that's why you need on your team, you need somebody with, sorry, somebody was saying something? Hello? Can somebody share something going on in their hospital that we can even just use as a case study? We've had one. It would be nice if we have 92 people on this group right now. So don't tell me none of you have nothing going on. Somebody speak up. I've been talking and my throat is dry. Even if it's something that you've already resolved, let's just share it so we can all, you know, get additional knowledge from somebody else's experience. I always say if you can gain knowledge rather than buy your own, is always cheaper. Learn from, gain from somebody else. Anyone? Is it that everybody is sleeping? Is anybody there? If it wasn't for the data problem, I would say we should all put on our cameras. Let me put on mine. Oh, where is it? Most times I try to keep it on, but sometimes, uh-oh, what's wrong with the camera?
We are here, ma.
We are
Thank
here.
you. I'm like, are you sleeping? Wake up. I've been gesticulating and talking all this while.
We are here, ma.
You have not been seeing your video, that's why.
Oh, so now it's on. I didn't realize actually. Normally I put it on. Once I start talking and I get carried away. So can somebody give us an example? Can somebody give us an example? Or something that's going on in your own practice, your own clinic, your own hospital, your own environment? Stay with me. We're almost at the end-ish. We've done the bulk of it. And just for full disclosure, this seminar was supposed to be shared. I don't know if our host mentioned it before I came on. I was supposed to teach with somebody else, but they were unavailable. So I had to take the whole day. So bear with me that you're having to listen to me alone for a whole day.
No, it has been very interesting, ma.
Thank you. Anybody with anything? Even if you come up with a hypothetical one. The person that wants to do research, what are you thinking of researching? I can't remember the name now. Mr. Was it Dr. that they're thinking about research. Miss Salma, do you want to say something? Go ahead. So nobody's talking, okay. Except the few people who told me that they're still here. Okay, so we'll continue. So data collection and analysis and reporting. So for data collection, basically you're aiming to gather reliable, accurate data that reflects performance and outcomes to inform decision making. So your data has to lead to decision making and whatever changes you want to implement. Okay, and when you analyze your data, it uncovers patterns, trends, and areas for improvement. Because that's the whole point of this. We want to improve the services we're providing. Okay, so then when we analyze the data, it should help us to uncover patterns, trends, and areas for improvement. We looked at the methods of data analysis, the benchmark, the root cause analysis, and others. So we don't need to revisit that. That's why I just kind of put a statement here. Those are all what we've covered before. And then reporting is it must be effective reporting because we need to make sure our stakeholders, our administrators, even us as healthcare providers get that information. Because that information is what helps us to request for more things. It also helps streamline processes, and it shows us where we need to pay attention, those items that we need to focus on. If there's something we're not doing correctly, we need to be able to do that. So when you even look at data collection, you want to clearly outline, and I said that to the person who spoke about research, you want to outline what you want to measure. Patient outcomes or process efficiencies, and you want to choose things that are measurable. For example, have a patient satisfaction score. That's one way of you being able to know information that you can decipher, that you can explain. Okay, functional outcomes, we talked about that. When you remove data, are you going to remove it from your surveys, from your patient's records, from your assessment, from operational data if you have electronic record keeping? So all those things, you need to make sure they're implemented. And you also want to ensure that your data is, the quality of your data is good. You'll see some research studies and, there'll be questions about data collection, integrity of the number of subjects, those kind of things. So when you're collecting data, you want to make sure you ensure the quality of the data. And that would involve things like how consistent was it, the accuracy, confidentiality. We cannot go away from confidentiality. We live in an environment where people talk anywhere, anyhow. And I'm talking in the healthcare field. Let me stick with that. We have to be able to, we don't have the HIPAA laws in Nigeria yet. It's coming. Privacy is coming. I think there was a breach on people's data that I heard about recently. I'm trying to think, was it the bank? No, it was I can't remember, some company that was doing something and they were selling people's data. Where did I hear this now? For like 100 naira per person. They were selling their data and they were found out and shut down. But so all these privacy laws are going to come to us as well eventually, because now we're in a global environment. When you start traveling around or working in different places, one country is going to know where you are from the other. We're doing a lot of electronic identification, so we can be tracked. So confidentiality is important to protect the patient's data and information. So even when we do the electronic records, we have to be sure that it's a secure system, and we're maintaining patients' privacy and security in terms of their data. And of course, when the data has to be organized in a way that it can be, it's organized and not confusing, clear, clean data, removing errors, duplication, and which is why it's easier when you do electronic data collection. It's easier to find systems that will help you like clean up your data and organize it. And then of course you have to have your analytics, your statistical analytics that you would use to analyze the data. This is not a statistic course, so we won't go into any of that, but just we've talked of some of at least our methodologies that we can use in healthcare. And data interpretation is also important in terms of identifying patterns and evaluating the impact of the data we've collected, assessing how changes or interventions will affect your objective and metric signs. Okay, and then, so that's analyzing, that's data, reporting, as I said, effective reporting. You have to know who your stakeholders are at all points, because they're the ones that are the decision makers. And you also have to know how often do you report. You have to have a standardized time, standardization throughout the whole process. So how often what's the frequency? Are you going to report every week, every month, every quarter? And depending how big or small your data plan, your project plan is, the project you're working in, you've got your plan that you're working on. Depending how big or small will depend how frequent you report. But you can have stages of reporting. Okay, like if your reports come once a month, but if there's an unusual change that you will do a weekly meeting, those kinds of things. So like we talked about the price increase, if something like that happens, you need to do it immediately. There has to be an immediate reporting to see, okay, this is outside of budget. What can we do? That kind of thing cannot wait till the end of the month. So that's why you have to fix your frequency of reporting as well. So going forward, okay, some of the methods that we looked for reporting on dashboards, that's if you have the electronic record system, real-time visual representation of your KPIs, such as infection rates or patient wait times, or the number of patients each therapist saw, or how long they spent with the patient. All those will be on your dashboard. Sometimes you can do scorecards, which is regular updated records tracking progress against specific goals, which would address patient safety or any treatment outcomes. So those would be, you would get that information from your evaluations, okay? Report to regulatory bodies, compliance with national or regional quality and safety standards often require formal reports. I don't know, our system is such that we're not there yet for something like this, but we do, please know, we do have a lot of regulatory bodies in Nigeria. Even for kids, for elder abuse, all those things, we do have a system in place. We do have these departments in place. People always think, oh, it's Africa, you don't have it. In Nigeria, no, we don't do that. Yes, we do. We have them. My only problem sometimes with those systems is they're not run very efficiently, but they're there. They sometimes they work. So we need to be aware of what regulatory bodies we have, because if a problem becomes really big and out of hand, you will be asked, did you go to the body that regulates this? And if your answer is no, then you're in trouble. I mean, when even we're looking now at the board is looking at surveillance in terms of quackery, which we know is a big problem in the healthcare sector. And if you know, there are a lot of I use physiotherapy. I use these physiotherapy places that don't have therapists. So now there's a formal way we can report. We've had it, but we pray that every time we have a system, it's efficient and it's effective. Because when people know that your system is not effective, then they abuse it. So, know your regulatory bodies. Presentations, when you're doing reporting, you share your data in clear, accountable format with the healthcare team to foster continuous improvement. Like the issue with this record thing, I mean, that's a whole project right there, how they can fix getting information from one department to the other. The biggest fix, like everyone kept putting in the chat, is if they had EMR. If they had EMR, nobody has to carry a paper file. Nobody has to start walking to the next office. They will come to you, you would get an alert that there's a referral for you, you would enter into the system, address the referral, and immediately the doctor's office will know that you've received it, you've addressed it, and then you can now send a message to them that this is what we're recommending. So EMR can I wouldn't say it can fix all ills, but it can definitely make communication more seamless. But then again, there's a lot of data breaching going on with IT. So you have to have a good security system in terms of your data. And also we have the added issue of power. So that's another aspect that comes to play when we're dealing with electronic record systems. So that was presentation. And then the feedback loop is basically where we're looking at the data discussion about clinical settings, such as morbidity and mortality of meetings, where lessons from adverse events are shared. So this is where it's talking about when things go wrong, we shouldn't hide them. Because when something goes wrong, it means something isn't right. So you need to assess what went wrong to be able to fix the system so it doesn't happen again. So, you have that's the loop they're talking about, morbidity and mortality. You have to address those issues, and that's how systems function efficiently without issues when problems arise and they're addressed and fixed and systems are put in place to prevent those things happening again. Also, when you're creating your report, you can have like an executive summary, which will provide like a high level of overview of all the key findings and recommendations. And I think for our friend who's having issues with the 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 transportation of a paper file, there needs to be an executive summary that's saying this is not working. This is what we're recommending. Well, we know EMR is already on the table, but maybe in the interim, what can we do to fix this? Can we hire, even if it's one tech or one porter or one person to help us? Because it's not going to be every day. So it's not like you guys will monopolize that one person. It's not every day you have patients that need to go back and forth. So that might be a quick fix. So you're going to give detailed information in your report that, look, yes, the nurses have been authorized to do this. It's not happening. The nurses are busy. They can't always wait. They don't have time to wait on us. Because when that patient comes in, invariably we have other patients that we can't just drop those patients to say, okay, let me see to this person quickly before they go. Because that other person too might have been waiting a while. And your goal is patient-centered care and quality care to get positive outcomes. So, you know, we're not providing quality care for these patients because they're waiting so long, and sometimes they don't get seen because the wait is so long. I mean, you are not at work 24 hours a day. So, you know, you have to have sometimes a summary that you can present that analyzes the problem in depth, the little pieces that you were seeing. They've said nurses can do it. Okay, fine. For them, the problem is solved, but it's not solved. So you have to go back. And visualization. If you need to, maybe not so much in your case, because there's no actual data we've collected, but you know what? That might be a good idea in your department. Document how often, one, you have students that can do the job. So they know that, okay, out of the year, actually, we only have students. In fact, how often do you have students? Can I ask that question? Is he here? Is he still on? Mr. Is it Umuna? How often do you have students? So you sometimes you want to, you're not doing major data analytics, but you're giving them data that, okay, in the last year, we had a student only from March to June. So students is not a fix because we don't have them all the time. Also, how many times do you have patients that need to go back? So that kind of information will help them say, okay, yes, we can hire a porter. You only need the porter 50%. So the porter will be available to work in these other departments. You that comes with your data are going to stand a better chance of getting that porter than somebody that just comes and says, we need one. So this data, and the reason that I was saying that it won't apply to you, but it does, is like visualization, giving them charts and graphs and tables with your data in it. When people see things, sometimes some people are very visual. It makes more of an impact in their minds. So I would do that. I would, if you can, document how many days in the year, if you can even go back to last year or a year from now back, how many days you had a student, how many, or going forward, you can start documenting, maybe in the next 1 month, do a study in the next 1 month. How many times you've needed to send a patient back with their folder? And how long are patients waiting? I mean, that's something you can correlate quite easily in your clinic. It's not in depth. You just have to even have like a checkoff where let's do basic paper and pen data collection. You know, if you don't have, we don't have EMR to know that, okay, you can go back and say, okay, this patient, they had to go back to the doctor and we couldn't follow up because there was nobody to go with the chart and we were busy. How many patients do you have? And how many times? Sometimes it's just one person working in the clinic. So that one person can't even leave. If there are two of you and your supervisor goes for a meeting, it means you're there by yourself. There's no way you can leave the patient and take somebody else somewhere else. So you can do like a basic report that includes some of this information that you can gather, even if it's within a month, whatever you can go back to and get. when people see facts, it's hard to say you don't need it. Okay? And dissemination of the report, you want to share the reports with relevant stakeholders through email, internal dashboards, or presentations. You have monthly meetings, that's a good opportunity. And feedback, solicit feedback from the stakeholders to ensure that the report meets their needs and to identify areas of improvement. If they don't give you feedback, it may have just gone right over their head, in which case you're not going to get a resolution. So you want to add, do you have any questions? Ask the stakeholders after you've done your presentation, whether it's 1 minute or 5 minutes or 10 minutes, that, okay, do you have any questions? Is there more information you would need to help you make this decision? You want to get that feedback. Okay. So I was going to have us take another break. I think we've been going for over 2 hours. I'm trying to keep track, but I can't. Just like a 10-minute or 15-minute break, and then we can come back for the last session. My co-host, is that okay?
All right, that's fine, man. So that means by 2:40, no, 2:50, we should be back.
Okay.
That's about 14 minutes. 2:50.
Okay. 2:50.
That's 10 minutes.
Okay.
Yes, please.
Oh, I'm looking at your
10
timer.
minutes.
That's what's throwing me off.
All right, man. So that's by 2:50 we should be back. So we can all go on break to return back by 2:50 now. Thank you, everybody.
Okay. Thank you. Okay, I don't know if we're all back. Hello, shall I start? I see the numbers actually, like 30 people maybe turned off their data whilst we're on break. I don't know if they're planning on coming back because we're down to 65 people. Mr. Olu, shall I go
You
ahead?
can continue, ma. Yes, ma.
Okay, okay. Yeah, because I see the numbers have dropped. Okay. So any questions or any comments or suggestions about what we were just talking about? I don't know. Somebody's screen, Kenny's writing on the screen. That's it. Okay. So the next portion or the last portion of what we're discussing is the impact. So you want to do an impact evaluation to see, basically assess what a specific QI initiative or intervention has produced. Did it produce its intended effects on the outcomes, patient care, and operation efficiency? Impact evaluation in this context goes beyond just measuring like the outputs and processes, but it also seeks to identify causal relationships and long-term changes resulting from the QI effort. In healthcare, impact evaluation is critical in understanding what we do. Not only does it affect the effectiveness of our intervention, but also it's aimed at improving patient safety, our clinical outcomes, the cost efficiency. We've been talking a bit about budgets and costs with the last scenario, and patient satisfaction. And so there are different types of impact evaluation. methodologies that can be used in QI. The first one is the experimental design, which is a randomized controlled trial, the RTC, where patients or the unit are randomly assigned to an intervention group or control group, allowing for the most rigorous assessment of an intervention impact. So if we're looking at outcome measures, then that you have an experimental design. So this is more a little bit into the statistical aspect. You have a little bit more of the experimental design can be either randomized per unit, just to compare either different patients or a whole unit. If it was a whole hospital trying to, if their project was on something that affected the whole unit, the whole hospital. The other type of evaluation is a quasi-experimental design. When randomization is not feasible, like in the above, where you can't have a random trial and a control, control group and not an intervention group, where that is not possible, you can use a method, it's difference in difference, or propensity score matching. I used to compare, you now compare the outcome between groups before and after the intervention. So if you can do a study where you have a control group, those that get the intervention and those that don't, then you can do the difference in difference, where you compare between groups before they had it, what they were doing, and after it was received. And then you have the pre and post studies, which compares performance measures or patient outcomes, again, before or after the implementation of the QI initiative. And you also have the interrupted time series, the ITC, which measures outcomes at multiple interval levels, again, before or after the intervention, to see if there are any trends or if there was any impact. And then the case control studies, which compare individuals who experience a specific outcome with those who do not, in order to assess the impact of the intervention. So part of the challenges when we look at some of the challenges of your evaluation, we can look at the attribution, the sustainability, the contextual factor is what we're doing. Are we in the appropriate context? And is it appropriate for what we're trying to achieve? And then also we talked about data quality and availability. And also the impact evaluation report should also provide an insight for future initiatives. This can include like summary of your findings. It would include your methodology, your context, your recommendations, and visualization. Ways that you can conduct this can be either through baseline and follow-up measurements, where we're collecting data and thereafter periodically tracking. You can also do a comparison to strengthen impact evaluation using control and comparison groups, which allow for you to assess difference between those exposed and those that were not. And your qualitative and quantitative look at quantitative looks at things like such as infection rate or readmission, and qualitative such as interviews with your healthcare providers, that person-to-person type of interview where you're gaining information, quality information, because you're going more in depth in terms of the information you are collecting. An example, a hospital that introduces a new hand hygiene protocol. We talked about that as being one of the things that can be posted in every part of a hospital because we've identified that it's a big area of infection. The protocol may use pre and post-op analysis to compare infection rates before and after an intervention, combined with the qualitative interview with staff to understand barriers to hand hygiene. So is it that the wash hand basins are too far away? They're not close to the rooms, they're not close to, because when you finish a procedure, you should wash your hand. So should there be one in every room? Are there hand sanitizers that are placed at regular intervals? So if you can't get to the wash hand basin, you can use the hand sanitizers, but also with hand sanitizers, there's a limit to how many times you can use a hand sanitizer before you should wash your hands. So those might be protocols that can be implemented to help with infection prevention. And when we talk about impact evaluation also, one of the things I mentioned is, are we getting the achievable results? And what areas do we need to work on? So you want to define your question. And we talked about that when we talked about the project management and having your plan. You want to clearly articulate and know what the impact of the initiative you want to implement. You want to, we talked about the different ways to evaluate. You want to select the correct evaluation design, and you want to choose a design that suits the initiative complexity and resources, like pre and post-op. So it needs to address that. Of course, you collect your data. You want to make sure, like we spoke about, data collection, it's accurate, it's clear, it can be concisely evaluated, and can be applied statistically, minimizing all your errors. And then you should be able to compare your findings using baseline data or control groups or benchmarks. So your baseline data, you got your information, control groups, either those that did or those that didn't. Of course, benchmark, you're comparing well, I don't want to use the word gold standard, but an organization that's doing it well, either an external benchmark or an internal benchmark that you would use to compare your results. And then, of course, you want to have your conclusion. When you evaluate, you have your conclusion. You want to interpret the results based on the goals and objectives that you set. And then here again, communication of your findings. You want to be able to share your results. Like I said, you need to share with the stakeholders, administration, because they are the ones that make the decisions and will implement any changes or add value to what you're doing by increasing the support. So when we conduct a rigorous evaluation, we can ensure that we have meaningful improvements in the care that we provide and our outcomes. So that's basically a summary of the final stage of your QI. We've kind of covered most or some of the methodologies, how we go about doing it, project management. The key thing now is implementation. And it is important for us to be able to implement these processes for us to improve our outcomes. Because a lot of times our outcomes really dictate the kind of support that we're going to get in terms of funding, in terms of when you do research and you're able to present that, okay, this is what the research has stated, this is how we can improve, this is what we can do, but this is what we need. That research now gives you a platform on which to be able to make requests and to improve your services. Because to improve services, it does take finances. To do all this that we just discussed today takes finances. Even if it's time finances, it's still, there's time and money spent in doing all of this. But I think what we need to keep an eye on is the end game, that basically our goal as service providers is to provide the best outcomes, provide the best services to get the best outcomes for our patients. And so I don't know if anybody has any questions, but that's really the bulk of what I needed to go over today. We're a little bit early, but like I said, somebody else was supposed to cover the other piece of this, but I think I've done justice to the whole, what we're supposed to present today. So does anybody have any questions? This is time for questions or suggestions or scenarios that we can have a little bit of time for discussion. Everybody is very quiet.
If there is any question, you can put it on the chat box. If you don't want to speak for now, then you can raise your virtual hand for questions or suggestions or comments as regards the presentation.
Okay, I mean, if there are none, then so there's references.
Mount, thank you. Can you hear
Yes, go ahead, I can hear.
me? I'm on the road,
Yes.
so there's noise. Okay, I want to thank you for the amazing presentation. You did justice to it. It's so straight to the point, so clear, and yeah, it was really, really interesting. I'm on transit, but I've been listening.
Okay,
So thank you very much.
Yeah, I was thinking professionalism, there's a lot with ethics but you know, this is an important topic for us to really address, because we're specializing, we're improving our skills, but all needs to be tied in with patient outcomes. I mean, really, that's the bread and butter of this, is that the whole concept of quality improvement is that we provide better outcomes for our patients. and for ourselves. I mean, if we are, what's the word? Not justified. If we are happy in the care that we're giving and we're confident, that's what I want. If we're confident in the care that we're giving and we're confident that we're always making sure the patient gets the best that we can do, I think that's really our goal, that, you know, the peer reviews are to make sure we stay on top of our game. And at the end of the day, when we basically go through QI initiatives, is to streamline the care we give, be more efficient, and provide patient-centered care. And I think, I mean, this seems like a lot of work if you're going to implement something, but what I try to do with the example that was brought up earlier is break it into little pieces. You know, like, okay, there's a problem taking a child from point A to point B. What can we do? And I think we should never be afraid to have plan A, plan B, plan C, and plan D. You know, when Thomas Edison made the light bulb, it wasn't on his 100th try that he got it right. So I think we cannot stop trying to improve what we do. And now with research, with all this stuff that the methodologies, they've made things much easier for us, ways to collect data, to collect information, and patients are willing to provide information. We are patients in other settings, even though we're healthcare providers in our own settings. So I think, you know, it might take us a little bit of time, but I think it's time well spent because it puts us at the top of our games, whichever profession we're in. And this is the way to do it. We have to just, and we can, like I say, you break it into little pieces, it makes it doable, rather than thinking, oh, it's a whole big project we need to do, we need this, we need that. Just start with the smallest piece, and you'll find once that works, you take the next piece, and you just, it's like peeling an onion. Eventually, before you know it, you're done. And the product of that is, you know, we're providing quality healthcare services. So thank you. Any other questions or scenarios or comments? If not, I think we can wrap up. Ms. Tolu, over to you. Hello?
Yeah, we're together, ma.
Okay, so yeah, I think we can wrap up if nobody else has any comments.
Okay, thank you so much, ma, for your time and sacrifice, because I know it's a sacrifice to be up that early to be able to connect and facilitate this workshop. I'm grateful. We are grateful for the great workshop and for having to cover up the time. And our other facilitator wasn't available because she had another engagement today, which was beyond our control. So I'm here to appreciate you for everything. And we are saying thank you, thank you, thank you. So in the absence of no further questions or comments or contribution, I think we can call it a day. Thank you so much, everybody. Thank you so much, ma'am.
You're welcome.